is a clinical professor of pathology and the Neuropathology Fellowship Program Director at the University of Michigan. She obtained her MD from Universidad de Antioquia, Medellin, Colombia. This was followed by a postdoctoral research fellowship at the Laboratory of Transcriptional and Immune Regulation for Neurodegenerative Diseases at Brigham and Women's Hospital in Boston, Massachusetts. She obtained her APCP training at Bay State Medical Center, which is in the Western Campus of Tufts Medical School in Springfield, Massachusetts. This was followed by a neuropathology fellowship at the Massachusetts General Hospital in Boston. She joined the clinical faculty at the University of Michigan in 2010. She is an active and busy clinician. The neuropathology division at her institution receives greater than 1,500 neurosurgical specimens, more than 300 intraoperative consultations, and greater than 300 muscles, more than 50 nerve biopsies, and more than 100 brain autopsies a year. Her clinical interests include neoplastic and non-neoplastic conditions of the CNS, molecular classification of brain tumors, and neuromuscular conditions affecting peripheral nerves and muscles in the adult and pediatric population. Her academic interest focuses on the implementation of telepathology, non-destructive optical imaging technologies, ex vivo microscopy, and image analysis. She has more than 90 peer-reviewed publications, 4 book chapters, and 1 book publication. Dr. Camelo-Piragua is an active member of AANP, currently serving as vice president. She is also a member of the Digital and Computational Pathology Committee at the College of American Pathologists. Without further ado, Dr. Sandra Camelo-Piragua will talk about intraoperative neuropathology.
Thank you so much for having me, and thank you for being here with me in this Thanksgiving week, ahead of this week. Happy holidays for everybody. So let's get into something interesting, intraoperative neuropathology. So I don't have any disclosures pertinent to this talk. Here are our learning objectives. Importantly, describe what is our role as pathologists in the intraoperative consultation of neurosurgical specimens, discuss clinical and radiologic data to formulate a concise differential diagnosis and provide intraoperative consultation of these specimens, and identify key cytologic and histopathologic features that will help us provide an intraoperative diagnosis. So what are the basic principles of neuropathology? First and foremost, I think you need to get to know your neurosurgeon in your institution. So you have to know how they operate. Are they going to send you tiny little needle specimens, 1, 2, 3, 20 for intraoperative consultation? Are they going to send you permanent sections after your intraoperative consultation, or what you receive in the frozen is all? So it's very important to understand how they practice and also understand what they are looking for. Are they just curious to know what's the diagnosis, or are they going to really do something different intraoperatively based on what you're telling them? So all of this is extremely important. So once you get to know that, every morning, if you are covering the frozen section for neurospecimens, it's extremely important to gather basic clinical information and radiologic information of any potential frozens, because this will already kind of narrow down your differential diagnosis for each of your patients, and it will make your life so much easier at the time of frozen. And try to gather from that information, what is the question? Try to understand what is the question. What do they want to know if they send the specimen for frozen? For example, if a patient had a previous glioma that was radiated and now has an enhancing lesion, maybe the question is radiation necrosis versus recurrent tumor. So you have to figure out, try to understand what is the question, what are you trying to answer, versus is this a de novo tumor that they don't know what it is and they just want specific diagnosis? Then you have to decide what you're going to do intraoperatively to achieve this. Are you going to do cytologic preparations like squash, smears, or frozen section, or both? And are you comfortable reading those specimens? Are you trained? And if not, then go with what you are more comfortable with. And the most important thing, in my opinion, is report only what you see. If you need more tissue, ask for it. Don't let yourself be pressured because the surgeon thinks it's A and you don't see A under the microscope. You just have to request more tissue. It's up to the surgeon to decide if they can safely send you more tissue or not. but just report only what you see. And once you communicate your diagnosis with the surgeon before you hang up, just ask them one more time, is there anything else they need from you? Because this is the time. This is the time if you need more material, if you need tissue to be sent for microbiology or whatever, this is the time to do it. So the role of pathologists in intraoperative consultations, for one, is to guide the surgeon. Is the surgeon in the lesion? It's one of the most important questions. Are they positioning the instruments in the right place? Are you getting the tissue that you need that has the lesion in question? Will your intraoperative diagnosis change the course of the surgery? Again, are they gonna move from a biopsy to a resection or not? Maybe it will, so guide the surgeon. The second one is to provide necessary information. And this is again, does the lesion explain the clinical presentation? So are you answering the question? That's important. If it doesn't match, if there is a mismatch of what you're seeing in the specimen and what the clinical question is, you have to let them know. Maybe you need more tissue. Maybe they are not in the right place. And put the lesion in a category. Often they don't need a final diagnosis. Just put it in a big category: benign, malignant, primary glial, metastatic, and go as granular as possible, but don't go beyond that. And maybe allocate tissue for ancillary studies, depending on what is done in your institution. So those are, in my opinion, the role of pathologists in intraoperative consultation. So we can have two types of specimens. We can have usually needle stereotactic biopsies, like this one, where they will have a little needle going to the tumor, and they may start slowly, and you don't know what end of the needle is what. Maybe this is in the center, but once you receive it, is not oriented. So you don't know which end of the needle or the specimen was the center of the lesion and which one is not. So for that reason, I usually recommend my trainees to take the tips of that needle biopsy and smear them. Smear both ends, because one of them is probably the lesion, hopefully both, but sometimes it's only one of them. Smear that, and then freeze the rest. But if in your institution, your surgeon this is the only thing they're gonna send you, and you're not gonna get anything else, then divide this in half and freeze half and leave the other half for permanent sections. Always leave something for permanent sections. On the other hand, if you receive open biopsies, well, it's easier, right? Just take a couple of representative sections that look different, smear that, and then freeze the rest if necessary, or representative as well. So one of the most important things in frozen section is to freeze the specimen as fast as possible. Have your block ready, and we usually use a heat extractor to, again, try to get the specimen as cold as fast as possible. So here we have a needle biopsy, and you can see how the trainee was putting both ends of the needle to prepare a smear, and use this technique horizontally, and have the fixative medium right next to it. Okay, it has to be placed immediately to avoid any drying artifact. This is here how we use this heat extractor, and we usually warm up the slide behind to allow the tissue to quickly get to the slide, and again, avoiding artifacts. Usually recommend 3-to-1 ratio between hematoxylin and eosine. That usually gives the best contrast, but it depends on how your institution has set up, if there is any specific rules of how they want to do their rapid H&E. But usually a 3-to-1 is best, in my opinion. So now we have to be aware of artifacts. Artifacts are unavoidable, and you have to learn what kind of artifacts you're going to be dealing with. Some of them you're going to be able to get along with, and others will be impossible to overcome. So the most common artifact is the freezing artifact, right? So you have all these ice crystals, it freezes too slow, and you're not able to tell what it is. This is where your smear becomes extremely important, because in the smear you at least have some cytologic features of your lesion. And if your frozen section is like this panel over here, at least you have some idea of what the lesion could potentially be, because your frozen might be uninterpretable. This is a slow freezing. In slow freezing, you can see that the outside of the tissue is readable, right? You can see what is going on over there. We have a lesion that maybe we can interpret, but the center of the lesion froze slower and is harder to interpret. So that's one. You have to make sure that your water baths are clean and you don't have a hematoxylin precipitate that may give you an impression of, let's say, bacteria or other things that can confuse your diagnosis. Be aware of like gel foam or surgical material that surgeons may place in the tissue as part of their procedure, or even like simple things like bone dust when they open and do a craniotomy. Sometimes they just have little pieces of bone getting inserted into the brain, and it's just iatrogenic, if you will. You will not see any reactive gliosis around it or anything like that. It's just iatrogenic. So be aware of those. Don't think that this is part of the lesion. The worst is a thermal artifact, right? And the thermal artifact will look like this. Everything looks red. Even the nuclei looks red. The background is very grungy and red, and this will be how the frozen section will look like. It's very difficult to tell what the lesion is. Perhaps you will be able to say, okay, it's hypercellular, and if this is frontal cortex, well, that's not normal. We are in the lesion, but we don't know what lesion is that, right? So just be careful. Let them know what you see. It's very, cauterized. Maybe send us a piece that is less cauterized. And then you can also have Crucian artifact of a small, high NC ratio cells, which sometimes is helpful to tell you is some sort of tumor or lesion with a high NC ratio. Knife artifacts, we are all familiar with that. Sometimes we can, read in between the lines, and sometimes we cannot. But those are more correctable, right? You just change the blade or get a new section, and that's it. And this is how an air dry artifact would look like. And this is bad in the sense that you cannot really read the chromatin. It's very difficult to tell, for example, is this a neuroendocrine type of chromatin, or is this a glial or lymphocytic chromatin? Might be harder, right? And also the cytoplasmic features kind of, again, go away with the drying artifact. That's why it's very important to fix your smear right away. So before we dive into intraoperative sections of different lesions in the CNS, I thought it would be important to make sure we know how normal look like, both on smear and frozen. So if we know what normal looks like, hopefully we'll be able to recognize what's not normal for that location. And the first thing is normal brain. So this is how normal brain smears in low power. Yeah, it's very pink at low power. You do usually have a good smear throughout, and you have these kind of islands of pinkish, right, in a background of neuropil, kind of grungy and glial, a mix of both, right? You have small blue cells, little dots in the background. And I always say, and this was something Dr. Hedley White taught me, in fact, that it looks more like when you go to the beach, right? It's like the sand in the beach, that the waves come and go and leave these little hills in the sand, which are these, right? So this is how a normal brain smear look like. Other people call it like cotton candy. That's how a cotton candy kind of look like. That's normal brain smear. At higher power, you will see that you have different types of cells. Again, per square area, if you will, it's not very cellular. Most of the cells very monomorphic, usually have very normal nuclei, right? Very symmetric. There are no bumps. They are very smooth, and you're able to identify perhaps neurons. Some of those little ones might be oligodendrocytes and so on. And the other thing is the background, as I was saying. It has this kind of granular that is more neuropil type background, mixed with these more glial processes around. This is how normal frozen will look like. I'm sure you're aware of that. So this is how normal it would look like. You have your neurons. They live alone. They live in the suburbs. They only have 1 or 2 neighbors visiting at the time, right? You don't want any satellitosis usually. This is how your normal brain will look like. So what about normal cerebellum? This is very important. Anything in the posterior fossa close to the cerebellum, make sure you don't call it lesion unless you know for sure. Don't overcall normal cerebellum a lymphoma or something else. So this is how normal cerebellum is going to look like. Again, pinkish, but it could be a little bit more cellular, and you can have a lot of those small blue cells around. If you're able to identify the big Purkinje cells, that's extremely helpful. And they are surrounded by the smaller neurons around. Again, here a couple of big Purkinje cells, very nice in the smear preparation. And then in the background, we have these little cells here. Those are the ones that usually get us into trouble Purkinje cells we can recognize, no problem. These ones are the ones that usually get us into trouble, overcalling them lymphoid or lymphoma, or maybe if you're thinking it's a young patient that may have a medulloblastoma and you have tons of these little cells, you say, oh, yeah, we're in the lesion, this is a medulla. Well, be careful. Go back and review. If they look monotonous, see, they are all very similar to one another. Again, the nuclear membrane is very smooth and you don't see any apoptosis or mitosis, right? So that's it. You may have a couple of larger cells. So these are probably going to be your granular cells, and these might be your Golgi cells or your basket cells. So just remember, what are the type of cells you have in normal cerebellum? This is how normal cerebellum is going to look like on frozen, but just be aware that you're not overcalling these little ones. Sometimes the chromatin is extremely dark, but sometimes you are able to see through and see this kind of salt and pepper chromatin typical of neuronal cells. So what about normal choroid plexus? Normal choroid plexus, this is a low power view. Notice at 1x how you have little clumps. You have clumps all throughout. If we compare this with our normal brain, it's very different. The normal brain, again, cotton candy, a background is very important. You have a background of kind of neuropil and glial cells. Choroid plexus, you don't have that background. You just have clumps in between. And if we go closer to those clumps are cohesive. They are usually around kind of forming papilla, if you will. Once again, the nuclei is very monotonous, smooth nuclear contours. And the other thing that is very important, we usually have these intracytoplasmic vacuoles. Very, very helpful. Remember, they are usually like cuboidal, so they have some degree of cytoplasm, yeah? And then this is how this will look like on a pap smear, for example, for CSF cytology. They have this kind of hobnailing of the cytoplasm, and again, a lot of intracytoplasmic vacuoles. This is how normal choroid plexus look like. Usually a monolayer of cuboidal, low cuboidal epithelium with these hobnailing cells, intracytoplasmic vacuoles, samoma bodies, etc. So now that you recognize normal choroid plexus, this is not uncommon. You have a ventricular lesion, they are going for the lesion and they happen to stumble upon the choroid plexus, send it to you, and you think that's the lesion. So first, is it normal choroid plexus or is it a choroid plexus tumor, right? So if it's a tumor, let's say a papilloma, then there will be like either more than one cuboidal cell lining, or there will be many more, right? Like a lot. You will fill the slide with choroid plexus like cells. This is normal pituitary gland. Normal pituitary gland may not smear very easily. Sometimes it does, sometimes it doesn't. But what is key here is, again, the background is very granular because it's a neuroendocrine organ, right? So you're going to have this granular background. The cytoplasm is granular. If it's normal, you're going to have different types of cells, right? You may even see secretions. That's also commonly seen. And then if you're lucky, this is how your frozen section is going to look like. You're going to have acinar structures. If it's a normal pituitary gland, right, versus an adenoma, that there will be loss of that acinar architecture, as you know, if we were to do a reticulin. But here we can see it very nicely. We have this nice acinar structure or nests. And finally, normal pineal gland. That's another one that is very tricky. That's very difficult. So it's very important you get familiar with how normal pineal gland looks like. Best thing to do is when you're doing autopsies, just take a section and familiarize yourself. But how do they look on smear? And this is the key. So here it is. Again, the cytoplasm is really fluffy, is very granular, and you don't really see a good membrane. It's there, but we don't see it, right? It's not very clear and it's very granular. The other thing, the nuclei is different to what I have shown you. So far, I've said most of the nuclei is usually very smooth contours. There is not much pleomorphism. This one tend to have some kind of grooves or indentations, and you can have what is very typical in pineal cells is what is called these nuclear pellets, are these little nuclear inclusions that you will find all over the place. And also you might be able to find pigment. And the type of pigments we see in the pineal gland includes melanin, usually in younger age, less than 3 years old, that starts to disappear later on in life. but more commonly melatonin, which is this kind of orangey type of color. And here, a little bit more of those nuclear pellets. I try to put different types. Of course, I cannot go up and down here because this is a still image, but those nuclear pellets can be humongous, but they are extremely helpful to tell you where you are and what type of cell is that. And this is how the pineal gland looks like. These happen to have a lot of melatonin, and you have calcifications. And again, they tend to be a little bit kind of in an acinar kind of architecture that you can appreciate on histology. So we've gone over what normal looks like. So let's go into a couple of the most common radiologic presentations of brain tumors. And this is as I say, very important. Review your OR list, check the clinical history, and check the radiology. And one of the most common ones is we have a patient with a rim enhancing lesion. What does that mean? So we have something like that. We have a patient that has a lesion that enhances in a rim pattern. The outside of the lesion enhances. That's a rim enhancing lesion. Every time we hear that, this is what we should be thinking. This is our differential diagnosis. A high-grade glioma, lymphoma, metastasis, demyelination, and infection. The order of this differential diagnosis is going to vary based on the patient's age and the history, right? What's important here is remember, lymphoma and demyelination are not surgical lesions. So we should recognize those if possible, because they are ideally, they are not going to resect these lesions. If you tell them that it's a lymphoma, for example, they will pull over and that's it. Maybe you can ask for a couple more cores for additional testing, but they're not going to resect the lesion. They should not, right? If you think it's infectious, what is very important, you alert them that what you're thinking so that they also send additional tissue for microbiology. So the classic history, if this is, let's say a 65, 70-year-old patient, then probably this is your differential diagnosis, right? In this order, that will be kind of the order. But if they say it's a 30-year-old patient who was recently diagnosed with HIV, well, the list changes a bit, and maybe you're going to put infectious on the top of your list. So this is your differential diagnosis, but the order may vary a little bit. So we're going to go over a little bit of how each of these look like on intraoperative consultation. So high-grade glioma. I mean, we know, right? First of all, we have to find the glioma. This is necrosis, right? If the only thing you see is necrosis, you have a rim-enhancing lesion, do not call it high-grade glioma or glioblastoma until you find cellular viable tissue of the lesion, because this could be anything. You can have necrosis in metastasis, in infection, in high-grade gliomas, in anything, right? Even in an infant. So no, you have to see the lesion. And here now, okay, now I'm happy. Now I see that I do have these glial cells because I have this pink kind of dense cytoplasm with lots of glial processes. So now I'm happy, right? There are too many, maybe they are atypical. And if I see microvascular proliferation, I'm feeling even better, right? Definitely glial in nature, all these glial processes, and I found mitosis. So now I'm happy and I can call it back and say this is a high-grade glioma. What about a lymphoma? Very important, very difficult. In fact, this is ones we have the most discrepancies, we pathologists, to call it on intraoperative consultation, yet it's extremely important to recognize. So on the smear, ideally in this one, we have tons of cells that had a very high NC ratio. You see the nuclei, and the nuclear membrane is quite tight to the nucleus, right? So high NC ratio. You might be able to see mitotic figures or even inclusion of macrophages around. But the majority in this particular case are these cells that have this particular chromatin, right? Which I usually call it like a soccer ball type of chromatin. And this is another smear from a different patient. Again, high NC ratio in this case, since this happened to be a large B cell, this is an immunoblastic type, so you're gonna have a very prominent nucleoli, but the key is high NC ratio, adhesive, and what we learn in cytology for lymphomas is the background also is very important. You have this, what we call the lymphoglandular bodies, right? When you smear it, the little cytoplasm kind of gets broken up and has these little globules on the background. That's very helpful. Lymphoma, especially the EBV-driven or that happens in immunosuppressed patients, tend to have a special type of radiology, and that is what is called an incomplete ring enhancement or an open ring, meaning that the enhancement doesn't quite go all the way through. So if you have something like that, think about an EBV or an immunosuppression type of induced lymphoma. Not 100%, but it's helpful. It's a helpful hint. So this is how lymphoma look like, low power, very important, kind of condensation of tumor cells around blood vessels. And this is not satellitis. This is way too many cells. It's not just a little bit of cells hanging around. It's like a lot of cells hanging around the blood vessels, and then sometimes they trickle into the surrounding parenchyma. At high power, you're able to see that, okay, this is high NC ratio. They look ugly. They may have mitotic activity, but on frozen section, it can be difficult to tell if this is a lymphoid cell or a glial cell. Particularly with the freezing artifact, the nuclei can become more elongated and give you an idea that is perhaps a glial cell when it is not. Here is an example of treated lymphoma. Again, necrosis, right? Necrosis, be careful to call necrosis a glioma, right? A high-grade glioma. In this case, we are like, okay, I can see some ghost cells, but ghost cells of what? Are we certain? Can we call it on that? Well, no. So we're probably just gonna call it necrosis and leave it at that. This is the frozen section or the area that we have. So you see that there is a vessel here, and we have tons of foamy macrophages. So this is how treated lymphoma usually look like. Tons of necrosis, an abundant number of macrophages. If you are lucky, you might be able to find a vessel that has some atypical cells here and there. But are you 100% confident that this is what it is? You may say suspicious. You have to ask, was the patient treated with steroids before this biopsy? So be careful, okay? So this case, in fact, this is CD20, and this is how the necrotic area stained like. This is necrotic, but even the CD20 was positive, so it was definitely very highly suspicious for a treated lymphoma. And we ended up sending this case for molecular testing that confirmed a mutation in the MYD88 gene and nailed down the diagnosis of a treated lymphoma, but not always possible. So just be careful. Those are very, very difficult. Demyelination, on the other hand, as you can see, I wanted to give you a low power view of how that will look like. Pretty hypocellular. It may look close to like how normal brain looks like. And what you're going to start seeing is like glial cells here and there, but tons of macrophages, a lot of macrophages in the background. This is how your frozen section is going to look like. So at this point, you're probably just going to call it a macrophage-rich lesion. And maybe if that's part of your differential diagnosis, if it makes sense with the clinical history, then maybe you say possible demyelination or macrophage-rich lesion. I favor this. But again, could it be a treated lymphoma? Well, again, depends on the history. So just go as far as you can, maybe open for a differential diagnosis, maybe say that you're not 100% sure, right? And that perhaps it's better to do more testing and for them to stop. And then if there is something that they need to go back and resect, then they do it at a later time. That's an option. This is this specimen. You can see here on this end, we have normal cortex. You can see our neurons here, very nice. There is no satellitis there. And here we have gray white matter junction. All of this is white matter. But as we move from this side of the slide to this one, you can see that there is much more cellularity over here. And when we go closer, the cellularity is due to these big kind of foamy cells that are macrophages. In this particular case, lots of CD68, occasional T cells and B cells here and there. And then here, in permanent sections, we see that the neurofilament shows a relatively preservation of axons and areas of demyelination. So this is an LFB in this end. You see that is more compact type of blue, right, myelin, versus here that you have lost that myelin. And if you look closer, you might even see macrophages phagocytizing that myelin. So that's an example of demyelination. And finally, metastasis. So you can have, every time we think about metastasis, usually most of the metastases, they go and they are separate from the surrounding parenchyma. They have a good transition of what is metastasis versus what is normal brain parenchyma around. And that is extremely helpful once we have the frozen section. But in the smear, it may look like this. So in the lower aspect of the smear, this is just normal brain smear, just like the first one I show you. And then on the top, just next to it, is hypercellular lesion of atypical cells that are cohesive, that have very well-defined cellular borders, and are in fact a metastatic carcinoma. Again, the ball of metastatic carcinoma surrounded by more normal or reactive parenchyma. Melanoma is a tricky one, right? Anything can look like melanoma. If you're lucky and you have the pigment, good for you. But if not, it can be very challenging. It's usually very pleomorphic. It doesn't always have the pigment. Most of the time, it is adhesive. Most of the time, it's not like a cohesive group like here. Most of the time, they are adhesive, pleomorphic, prominent nucleoli. If you don't know, you can always just call it malignant neoplasm, fibro metastases, including melanoma, for example. Or can you tell, is it a glioma versus metastasis? That's very important. Well, we don't see glial processes coming out of these malignant cells, right? So that's probably a metastasis. Obviously, the frozen section here helps us because, again, we move from gliotic parenchyma to a very hypercellular lesion, right? All right, so that was the differential diagnosis for rim-enhancing lesions. So don't forget about it. That's what you should be thinking of. Let's move to the other one that is relatively common as well, which is a cystic lesion with a mural nodule. So every time you hear those buzzwords, this is what you have to think. This is an example of this posterior fossa lesion, very, very, very large cyst with a mural nodule that enhances. So this is kind of the most common, the four most common tumors. There are new entities in the WHO that can appear with a cystic with a mural nodule, but I'm going to focus in the most common that are these four, okay? Pilocytic astrocytoma, hemangioblastoma, ganglioma, and PXA. So again, depending on the clinical history, you may switch how your differential diagnosis goes. Pilocytics and hemangios, they can happen anywhere, but certainly in the posterior fossa versus gangliomas and PXA, they are mostly supratentorial. So it may change the age and the location, very important. So here is a smear preparation, very different from our original normal brain smear. We have tons of glial processes, a lot of cells in the background, right? It's kind of cellular. One thing that is important is notice that you have these very long processes, bipolar cells with very long processes like pyloid, right? Like your hair. So there they are, very long. See that these bipolar, very long, thin, delicate processes. And we're lucky enough that we found also some rosenthal fibers embedded into this glial lesional tissue. In the frozen section, you might be able to see the biphasic nature of the tumor, solid areas where usually the rosenthal fibers are, and more microcystic areas like here. Pilocytics tend to have hyalinized vessels. That's a feature, and they may even have microvascular proliferation. So be careful. They can also infarct on themselves so that you can have microvascular proliferation and necrosis. So be careful, be careful. Usually they're not very mitotically active, not very typical. So again, clinical history, location, radiology. Versus this is the hemangioblastoma. I always think hemangioblastomas, like tons of capillaries, is a mesenchymal type of tumor, right? So mesenchymal lesions tends to stay together. They are not going to smear very well. You see in this one, there is nothing in the background around. They are sticking together in little islands. You don't have any glial background. You don't have any neuropil background. They are cohesive. And this is how it's going to look like. Those are your stromal cells that they can look very pleomorphic, in fact. And if you're lucky enough to, be able to do an intraoperative or, oil-redo frozen sections, you're going to see that they are filled with lipids. That's very helpful. And this is a very well circumscribed tumor. So this is one of those that they may send you a piece of cerebellum, and you have to be aware of how normal cerebellum looks like versus the lesion that is right here, because they are well circumscribed lesions, right? And ganglioma, as we say, they can happen anywhere, but most commonly supratentorial, most commonly in the temporal lobes, but they can happen anywhere. And then you're going to have a mix. You see the background, we have a neuropil and some glial cells and maybe some funny looking neurons. So if you find neurons that are binucleated, that's not normal, of course. Or if you're like, well, this cytoplasm is very unusual, they're clustering together, and then you have also a mix of glial cells, that's helpful. Maybe you can have some calcifications and inflammation around. So here is an example of a ganglioma with clusters of atypical cells that are sometimes binucleated, vacuolated. So there it is. PXA, on the other hand, again, usually supratentorial, usually also very close to the pia. And then they're going to have these horrible looking cells, multinucleated, tons of atypia, but you look and look and look, and you almost, hard to find mitotic figures, for example. For the most part, you will be able sometimes to find EGBs. So if you have EGBs, eosinophilic granular bodies, in a setting of abundant atypia, be careful, back off, think about it. Could this be a PXA? How's the radiology? What's the age? What's the location, right? Here is a frozen section, again, relatively well circumscribed. This is the lesion, and this is gliotic brain parenchyma on this side. And if you're lucky, you find the xanthomatous cells. And also if you start seeing lots of eosinophilic granular bodies, that kind of helps you support that this is most likely a PXA. So that's the differential diagnosis for cystic lesions with a mural nodule. Let's think about the other way to think about this is what is the location. So you can have a differential diagnosis by location, okay? So depending of where a tumor is arising, then your differential diagnosis changes. For example, if you have a base of the brain anterior lesion, you are probably not going to think of an ependymal tumor. You maybe think of something that is dural-based, like an like a meningioma, or maybe an olfactory tumor, or something along those lines. Versus if it's a tumor that arises in the ventricles, then your differential diagnosis is going to change. So let's, for example, think about dural-based lesions. This is like a kind of overview of what is the main differential diagnosis of dural-based lesion. The most common, most of the time, is going to be a meningioma. Other options include a solitary fibrous tumor, certainly metastasis, lymphomas, sarcomas, you name it, right? But these two are the most common. And then how radiology can help us. Meningiomas, as we know, dural-based, usually the radiologist will describe that it has a dural tail, and it usually has kind of enhancement that is relatively homogeneous. In T2, though, they are the color of the tumor is similar than the cortex, okay? Versus solitary fibrous tumor, they call it less evident dural tail. When you're lucky, they don't have much of a dural tail in general. And they have what is called the yin and yang pattern in T2. So in T2, we see how different it is. So this one looks similar than the cortex versus this one has areas that are similar than the cortex and areas that are similar than the white matter. So that's called the yin and yang pattern in T2. And often have these flow voids. So those are kind of buzzwords that you may be looking for in the radiology report to help you guide you one way or another. But of course, then we have the intraoperative section. And I think meningiomas are one of the most beautiful tumors to diagnose by smear. They smear very, very, very well. In fact, for example, when you have a CP angle tumor, where your differential diagnosis may include, let's say, a schwannoma versus a meningioma, smear is usually the savior for me, because meningiomas will smear very well. Schwannomas, they are mesenchymal tumors. They will stay together, right? So if you have areas or islands of tumor cells, and in between you have cells that have smear out, that's very helpful. And meningiomas have this kind of abundant cytoplasm, that it kind of, I call it like a similar disease. This is the best description I've ever had. Again, this came from Dr. Haley White that taught me this. It's like a skirt flowing in the wind. See how fluffy it is. The cytoplasm falls on itself, or a scarf flowing in the wind. This is how meningiomas look like. That's the typical cytoplasm of a meningioma. Then if you're lucky and you find whorls and psammoma bodies and intranuclear inclusions, the diagnosis is made. Usually, we can diagnose this on smear. We usually don't need frozen sections for that. But if you want to do it, go for it. On the other hand, solitary fibrous tumors, they don't smear as well. And you're going to have, for example, here we have an island of dense tumor. And if we get closer, yes, some tumor cells are going to come apart. There you go. They're coming out. They're coming out. But they are kind of small, oval, and naked nuclei. They do not have abundant cytoplasm. Okay, so that's your typical SFT smear. Oval, spindle, and minimal to no cytoplasm. This is the frozen of that case. That's a very hard frozen. It's tons of, dense collagen and some cells. Is this a fibrous meningioma? Maybe. Is it something else? Maybe. We don't know. Is it a metastasis? Is it a lymphoma hidden in there? Maybe. This is the permanent section of this particular case. And obviously, once we have the permanence, it's easier because we have our STAT6 that we can diagnose SFT with confidence. All right. So I think we're doing good. And we come into the virtual slide. So the virtual slide that was provided is that the clinical history is that of a 55-year-old woman who had intermittent left and hand numbness, weakness of left lower extremities, and imbalance when walking. So all of this was kind of coming and going and progressing for the last year. And then on MRI, there was a T2 hyperintense intramedullary lesion with possible enhancement on the C4, C6 region that you can see over here. So I think I have time, and I'm going to try to walk you over the provided slides. So this is the smear. Forgive me, this is kind of an old case, so the slide had faded a bit. But I just want you to observe how we have these kind of islands of tissue, and it's relatively hypocellular in between the islands. When we get closer, we do have definitely some sort of pigment maybe, and maybe we do have some glial processes here. It's not very cellular though, not very cellular. And let's see what else we find. So we find a lot of these guys running around. Those are rosenthal fibers, right? I hope you guys agree with me that these are rosenthal fibers. This was the frozen section, and the frozen section confirms what we saw. This lesion probably bled in the past because we have a lot of hemosiderin-laden macrophages, and we have numerous rosenthal fibers, numerous rosenthal fibers. All right. I think this is the permanent section of the frozen. There we go. And again, numerous rosenthal fibers with a lot of kind of hemosiderin-laden macrophages here and there. So I have to admit, this was about 6 months after I started my job here. I was a newbie out of training, and I look at this. I saw these rosenthal fibers, and I call very confident and say, this is a glial neoplasm with rosenthal fibers, most likely a pilocytic astrocytoma. And then I went home and slept, went to bed, no problem. And then the next day, let me see, where is my presentation? There it is. There we go. All right. So we went over this. So next day, this is what I saw. The permanent sections showed this area and this at low power. I was like, well, that low power, this is not looking like a pilocytic. At low power, I have vessels and I have nuclear free zones around vessels, and then I have some cells. This just looks like an ependymal tumor. And this area is filled with Rosenthal fibers versus this area, again, has these more cellular monomorphic round cells with pseudo rosettes around blood vessels. Here is the permanent pseudo rosettes, GFAP accentuated around the blood vessels, and EMA prenuclear dots. So this was an spinal ependymoma. And in fact, what I had was what is called pyloid gliosis, right? So one has to be very aware of the potential pitfalls one can encounter in frozen section in neurofrozens. And Rosenthal fibers is one of them. Similar than necrosis, do not call anything pilocytic astrocytoma just because you see Rosenthal fibers. You have to find the glioma as well, right? You have to see, okay, are those Rosenthal fibers due to what? So here is a differential of things that can have pyloid gliosis around them other than pilocytic astrocytoma. So any of these lesions can have abundant pyloid gliosis around. And if this is the only area that they biopsy and they give you, you can go down the wrong path. I think we mentioned a little bit about macrophage-rich lesions. Again, let's say in a rim-enhancing lesion, if you see tons of macrophages, back off before you call it a glioblastoma, right? These are things that can have macrophage-rich lesions. And one of the biggest pitfalls is, again, is also this clear cell renal cell carcinoma. The cells can look like macrophages. So look at the clinical history. If the patient has a history of renal cell carcinoma already, and you're seeing this, consider that. Of course, they can have an abscess, they can have, infectious or whatever, but just consider that in your differential diagnosis. Prominent inflammatory infiltrate is another one, particularly germ cell tumors. So tumors that arise in the pineal or in the pituitary or hypothalamic region, especially in young patients. If you have tons of inflammation, consider you may have a germ cell tumor hidden behind. All right, we're doing with time. So the next slides, I'm not gonna go over them in detail, and this was put together mostly for your reference in the future, but I have differential diagnosis by anatomical location. So if you have a CP angle tumor, what should you think? If it's a tectal tumor, or they can also call it quadrigeminal plate or pineal region tumor, what's your differential diagnosis? And so on and so forth. For example, in the CP angle lesion, I usually use the SAMC kind of mnemotechnique, right? This is the SAMC, the kind of tumors that can happen there. Schwannomas, arachnoids, aneurysms, meningiomas, etc. For this SAMC, usually the A almost never comes to frozen section, but the other letters will come. So have them there in your differential diagnosis. And so on and so forth. So I provided you with some differential diagnosis, a little bit also radiology and anatomy for you to be aware of what kind of structures are located in those areas and what should you be thinking about it. So in summary, and we're doing good with time, in summary, I think the key of neuropathology or pathologists doing intraoperative consultations for neurospecimen is always review clinical history before you go to the frozen section. Check the age, what is the clinical presentation, and what are the radiologic features, so that you try to, one, figure out what is the question that you're trying to answer, and hopefully, combine that with location. Where is the tumor located? When you combine these two, you most likely are going to be able to formulate a narrow differential diagnosis in a certain order, depending on all those parameters. And then you do your frozens. Either you do smears, or you do frozen section, or you do both, depending on what you have available, what are you comfortable with. And then you report only what you see. Only what you see. That's very important. And the next thing is, are you answering the clinical question? Does it make sense? Does it explain the radiology? Do you need more tissue? And if you do, just ask for it. Here is our wonderful fellow. We have wonderful fellows here. This happened to be Dr. Becker that call in, right? And always before hanging up, is asking, do you have any other question? Is there anything else you need from us before we go? Okay. So that's pretty much, I gave you some references, and I hope you all have a wonderful day and week. And I think we are open now for questions.
Okay. Can you hear me?
Yes.
Okay, good. Does anybody have any questions? I don't see anything written in the chat box here. Maybe there are no questions.
That's my timer.
All
Well.
right. Well, if we don't have any questions, thank you again for joining today's AANP Teaching Rounds presentation. We would ask that you take a few minutes to complete a short evaluation. Completion helps ensure accurate reporting to the accreditation board. A link to the evaluation will appear on your PathLMS screen upon the conclusion of the Zoom meeting, or you can navigate back to the main course and select the evaluation option. Once you've completed the evaluation and selected your credit amount, please then select appropriate certificate based on your credentials. The PowerPoint slides and recording will be posted to the AANP website in the next week. Thank you again to Dr. Camelo-Piragua for an excellent presentation. This concludes the session for today.
Thank you. I guess I just saw one question quickly before we go. I think the question is, do you routinely consult patients' EMR? And the answer is yes, but I'll go to the radiology, number one, and then a little bit of the surgeon's note of the clinical presentation, like how did the patient got to be their patients, go to neurosurgery, what's the clinical history? Let's see. Yep, I think that's it. Thank you all. Have a wonderful Thanksgiving. And you have my email if anybody has any question in the future. Thank you.